Welcome to Heart Blocks. In our previous section, we focused on arrhythmias that arose out of the AV junction, either SVT or actual junctional rhythms. In this section, we'll talk about what happens when that portion of the heart isn't functioning properly at all in terms of actually shutting off or delaying. Quick reminder, AV junction is the AV node and the bundle of His as a group. The sinus node, those rhythms I'm actually going to reserve for the advanced arrhythmia group, and that'll be part of that lecture when that comes around. But without delay, let's dive right in. All right, all three of these strips, they are slow, bradycardic, fairly obvious just by eyeballing them. I'll go ahead and number these as 1, 2, and 3. What makes them unique, though, is that the first one has a nice even cadence all the way across. The second and third one, they're missing beats right in the middle. So let's do a few things to help pull apart what makes each of these three strips unique. What I really want you guys to learn is that you don't just have to say it's a missing beat. You can actually dig down and say exactly what type of missing beat it is, because it does, matter, especially if it happens frequently in a patient. But we'll start by just measuring this one real quick. And that distance across here is 35. 1500 divided by 35 gives us a heart rate of 43. So that is most definitely sinus bradycardia, and nothing too exciting about that. Now for number 2 and number 3, what we need to do is actually measure the distance of the P to P. And what we're looking for is that the gap P to P is exactly 2 times the previous. And so to do that, we'll swap colors again, and we'll say that ours starts right about here, about halfway through, and it probably about right there. So for that we get 17. And then if we measure, and I realize this one slopes up a little bit through here, but I think our most definitive start point's about here. And this gives us a distance of 34 small boxes. So we wind up with double, because 17 times 2 is 34, which is exactly what we were looking for. Now, if you compare this to our next one, where if we measure the P to P on strip number 3, we will start right here at the very beginning and come to about here, and that's 5, 10, 15, 16, 17, 18 small squares. And this guy way out here stops about right there, and that is 5, 10, 15, 20, 25, 30, 35, 36, 37, 38, 39, 40, 35, 39, 40, 41, which is well over double, because 18 times 2 is 36. So, plain and simple, that's what we're after. Is in the second strip, we do not meet that criteria of being exactly 2. We have gap greater than 2 times P to P. Why is that important? Why do we care? Well, what that does is makes the difference of calling this one sinus rhythm with sinus exit block, and this one is sinus rhythm with sinus arrest, which is exactly the idea. All right, so we'll move forward and I'll walk through exactly what makes up the rules for deciding this kind of stuff. Sinus exit block. What is it? Well, frequently we just call it sinus block. We don't always add the exit. But what it means is the sinus node initiates the impulse. So the sinus node is doing its job. It's making a beat at a regular interval. What makes this unique is, for whatever reason, that impulse is not conducted. It just never leaves the SA node. And that's why we have this blocked here on the picture, because it occurred within the sinus node, but that cascade as it travels through the rest of the atria and the heart never happens. And that's why you have no P wave and certainly no QRS. They're actually fairly simple to identify. All you really need to do is measure, and I have it written out in the long form, which is the duration of the pause is exactly twice the P to P interval of the previous 2 beats. Or more simply put, the gap is exactly 2 times the P to P interval, which you saw me do earlier, and we'll practice it again going forward. Another way to look at it is that it's essentially sinus rhythm with unique and exact timing. And that's what's really important, is that exact timing. The rules aren't terribly challenging for sinus block. The rate may be bradycardic, or it can be, up to a higher speed like 100. What really matters is that it's going to be irregular. There may be a pattern that occurs with the missing beats. Oftentimes, this may not be just a single dropped beat. It could be happening fairly frequently to the point where it makes the patient symptomatic, and that's why we focus on it, and it matters. Again, what's the important part of this is that the gap is exactly 2x of the previous P to P interval. Your P waves should look perfectly normal, 1 for every QRS. Just in this case, there won't be a P wave with the missing beat. Your PRIs should be perfectly normal, as well as your QRS. All right, so for sinus exit block, we'll go ahead and get our numbering going like always. There's just a little bit of an 8 there. So we have 8 times 10, and so we have a normal rate. Our regularity, well, we don't have that though. We are irregular. We have missing beat, no pattern, and no real ectopy either. Other than the missing beat, this seems to be a perfectly regular heart rhythm. We'll look across at our P waves, and those are upright and uniform. We have 1 P for every QRS. We'll check our regularity, and since we have a missing beat, we want to know what the P to P is anyhow. So if we go from just a hair in front of here to just about here, that'll give us 19. And we'll check our gap, which is here, and that is 38. So we can say gap equals 2 times 19, which is 38. So we have that exact match that we were looking for, and that's a good thing. Our usual stuff, we'll go ahead and get our PRI measured out, and that's what. So that's right at about 1, 2, 3.5. So 3.5 times 0.04 gives us 0.10. No, sorry, 0.14. And then the QRS is going to be 2.5. As for the QRSs, those are uniform, and they have the QRS pattern. And that's all we really needed. We have a normal rate, a normal PRI, and normal QRSs. So this really is just sinus rhythm with sinus block. And doesn't that just sound better than saying sinus rhythm with a missing beat or missing beats? Now you can specifically hone in on what type of problem you're encountering. So, why is sinus block important? Why am I taking the time? Well, with any missing beats, the big problem is if they become frequent or prolonged, you wind up with bradycardia. Now, if they just happen rarely and the patient is asymptomatic, you don't really have anything to focus on and just keep an eye on it. But if they're bradycardic and then it gets to the point where either it's so irregular or you wind up having, symptoms of decreased cardiac output, at that point they're unstable. And when you become unstable, at that point you get to follow your ACLS protocol for unstable bradycardia. Just to review this real quickly, it's pretty straightforward. If it's due to a medication, stop that. Pretty straightforward, right? If they continue to be unstable, your quick interventions are going to be atropine. If you have IV access, try and get that. If you don't have IV access, your next best one is going to be pacing. And that'll start with transcutaneous. Or if it looks like this is something that will be prolonged for several hours or more, you may need to do transvenous. Of course, both of those are temporary. And then we'll see how they do from there. In the meantime, with all of this, your other option as well can be, especially if the atropine works, start them on a dopamine or other recommended medication to help speed up the heart rate to assist. To go back to triggers, medications is always a big one. Ischemia, if it's related to an MI, inflammation related to surgery or other problems, and actually high vagal stimulation, particularly in sensitive patients, can cause a sinus block to precipitate. The only other thing that I would add is if the patient, they may wind up having an escape rhythm that takes over to help get them through this. It's just something you'll have to be on the lookout for. What is sinus arrest, or the mechanism for sinus arrest, also known as a pause, which I think is a really good explanation of what's occurring. Essentially, in this situation, the sinus node completely fails to initiate or create an impulse. Lots of different causes, but it's been depressed or turned down. And when you have the complete failure of initiation, nothing happens at all. Essentially what occurs is you've got your P waves. I'm just going to draw the P waves here, not worry about the QRS. And what happens is you have that failure occur and it completely resets the system, and then the next P wave occurs and the sequence and the timing is out of whack. And that's where your real big clue comes in, is that the duration of the pause is not an exact multiple of the other P to P intervals. So what we can say is that the gap is not equal to 2 times the P to P interval. The reason why we say not equal is it can be short. Typically it's longer, but you may come across ones where it resets itself and it actually manages to kind of speed up a hair, which we'll look at that. But ultimately, the important part of a sinus arrest or sinus pause is that you don't have an impulse being generated. There's just nothing there. And that's why things get out of sequence. As opposed to the sinus block that we just talked about previously, where that impulse occurs, it just doesn't go anywhere, which is why sinus block can maintain that cadence, can maintain that pattern of beats, whereas sinus arrest that we're looking at now winds up essentially resetting itself. Resets the timing. As for the sinus arrest rules, not terribly different from the sinus bradycardia or sinus block that we talked about before. The patient can be bradycardic if it happens frequently enough, or they can have a relatively normal rate with just occasional missed beats where they've paused. So your pattern will typically be irregular, but there may be a pattern as well. The duration of the pause, again, the gap is not exactly 2 times the P to P. Otherwise, your P wave will have a uniform shape, the PRIs should be normal, as well as your QRS duration. Right, we'll start as always. Yes, this is in the 2 lead. We got 1. So 8 times 10. I got a normal rate for that. Our regularity, well, it's definitely irregular. We have missing beat. There's no pattern. And there is no ectopy. We can go through and we'll be able to figure out what our actual rate is, but let's go to our P waves first. The P waves are upright and uniform. I have 1 P for every QRS, so we're good there. Now we need to check the regularity, which also winds up helping us because we have a missing beat and we want to check that P to P interval. So I'll just do the P to P equals, and we'll go ahead and mark him right here. And then we'll mark the next one right here. And that comes out to exactly 15. And then if we measure this space across here, we wind up getting 29. And in fact, if I measure back this direction as well, this one comes out to 15 also. So we get 2 different things here. One, the P to P is 15, and of course if you multiply that times 2, that equals 30, but the gap equals 29, which is not an exact multiple. And that's what we were looking for, correct? A hint or an indication of whether this is sinus block versus sinus arrest. As for the rate, we still stick with 80 because it's irregular. Without that missing beat, our rate would be much higher. The PRI measurements, we can go ahead and get those real quick like. And we'll just use this one because it starts and ends nice and evenly. That one's probably right about 3.5. 1, 2, 3. 0.14, and that's normal. And our QRSs are uniform. We have a very small Q wave. Now we have QRS pattern and 2.5. And that is normal as well. So what we have is sinus rhythm with sinus arrest. And that's the goal. What's the difference between sinus arrest versus sinus block? Why do we care? Why do we bother doing any of this? In both cases, the problems remain the same. You know, if the patient gets bradycardic and becomes symptomatic, that winds up getting us excited, right? Because all those decreased cardiac output type symptoms, you know, will pop up: syncope, dizziness, hypotension, etc. The irregularity of the pulse can be a problem. Patient may feel palpitations because of that. What separates these two ultimately is that sinus arrest is considered more dangerous than sinus block, and that makes sense, right? The fact that that sinus node didn't even turn on or didn't even try to make a beat during those instances, that's why it's worth digging into and being able to identify the difference. Regardless, whichever one of these there are, if that patient is symptomatic and winds up being unstable, we need to follow ACLS. And just like I'd mentioned before, you know, you got to try your atropine. Of course, figure out what's triggering it. If it's a medication, stop that if you can. If the atropine doesn't work, or if the patient continues to be more symptomatic, or if you can't get the atropine quickly enough, we need to do temporary pacing, whether that's transcutaneous or if you really need to, you can do the transvenous, you know, the temp pacer wire. And then ultimately, if they're hypotensive or it looks like it's going to be a while, and if they're responsive to the atropine, doing dopamine. A dopamine or epinephrine drip, whatever winds up being the protocol for where you're at. And that's why sinus arrest is important, and that's how you intervene, because it's, you know, a symptomatic bradycardia, essentially, from an ACLS standpoint. The mechanism behind a missing heartbeat can be identified by which of the following? It's not worth the time and effort, just notify the nurse and physician. It's good enough. Yeah, I'm going to say that's not the right attitude. Measuring the PP of the previous two heartbeats? Absolutely. Think back to our sinus blocks and our sinus arrests. That's what we're focusing on for these questions. So measuring the P to P is absolutely important. Measuring the P to P interval of the gap. So previous two heartbeats and gap. Definitely need to do that. Determining if the P to P of the gap double the P to P of the previous two. That's all part of this. Or, you know, just order a 12-lead EKG and let the physician determine the mechanism. Don't do that. Make the time, make the effort, try and figure out exactly what's going on. You have the tools you need, you might as well use them. So for this one, I definitely go with those three in the middle there as being the answer. So for you advanced arrhythmia folks, I went through all this really quick just so that you still had that content to refresh your memory with. The part that I'm going to take you to beyond what you learned in basic arrhythmia is that with our third degree blocks, you are actually going to be responsible for identifying if it is a junctional escape or if it is a ventricular escape. And in my defense, just because it was the way I was trained, so I occasionally let this slip, I also call it idioventricular. And the idio means arising from. So you've got idioventricular, also known as ventricular escape. And that's what's going to be really important with this section. We're going to go through essentially the same strips and a couple extra that you did prior, but we're going to add in that next layer of identifying which type of escape rhythm you have. The other thing that we're going to spend some time on, because it's really interesting, is the high-grade blocks. And that's where you have several P's in a row, or I should say, yeah, several P's in a row without any QRS. And that's a way of identifying exactly how bad it is, especially in situations where you don't have a good second degree type 2 where you can make a nice ratio out of it. You can just say high grade block. In fact, high grade block is a form of Mobitz type 2. We'll dig into more of that as we go. Other names for high grade block may also be advanced second degree heart block. Both are acceptable. Which of the following statements about AV blocks are correct? We'll just go through these one by one. First degree AV block will occasionally drop a QRS. Nope, we know that's incorrect right away because first degrees never drop a beat. Second degree AVB Type I has a consistently wide PRI with no dropped beats. That's wrong because we know all second degree blocks drop QRSs. That's one of the hallmarks of that. Second degree Type II has a consistent PRI, which is correct, no matter what pattern of dropped beats. So that one is actually correct because second degree Type II has dropped beats with a consistent PRI. Last but not least, third degree AVB has total AV dissociation. That's accurate. Atria and ventricles do not conduct impulses across the AV junction. So on this one, I would say that your third and fourth options, those two are accurate statements. To finish out with this one, for the advanced arrhythmia group, I realized going through this was pretty slow and pretty awful, but what's important for you guys is to note that this is a high-grade block. And why is it a high-grade block? Because you have more than 2 P waves in a row that were blocked. So this is a second degree Type II high grade. And being able to say that and point that out really just shows that the level of severity of what's going on. You know, it's beyond a ratio at that point, but saying that we're missing multiple heartbeats because of what's going on. To add another layer onto the second degree Type II interpretation, I just want to make sure everyone's aware of this. It is this idea that in many, many cases you will have a PRI that is longer than normal. So like in this one, I've already marked it, but I'll go ahead and remark it again, that you have a PRI that is 6 small boxes. 6 times 0.04 equals 0.24, and that is long. Now, in any other rhythm, you would call that a first degree AVB, wouldn't you? And that would be appropriate. However, to say something like first degree, second degree Type II doesn't make as much sense, nor would it if you said second degree Type II with a first degree. It confuses things. to a certain extent. So what we do instead of saying first degree, because second degree block is a continuation of first degree. So you think about it, in second degree block, that's happening because the AV junction is broken in some way. First degree block happens when the AV junction is broken in some way. However, second degree is worse. It's more broken. So it makes sense that you could have a slightly broken problem, first degree block, advance to the point of having a second degree, and both are occurring at once. And so for that reason, we actually let the second degree block stand out as being more important because it's more severe. You're dropping heartbeats. That's a big deal. And so instead of saying first degree with a second degree or whatever, we just say what's written up above here, second degree AVB Type II. And again, this is only with Type II that we do this. Doesn't matter for Type I because you expect them to get longer. Second degree Type II with prolonged PRI. And that's the idea there, is we want it to, we need to make mention of it because, well, we bother to read it and mark it out. And it just helps indicate everything else that's going on. So please keep that in mind going forward when you're doing interpretations, that it's worth noting when that PRI does wind up being long. All right, advanced class. This is in here not because I'm trying to trick you, but simply because I want you to think about the world in a little bit larger light. You have a 2-to-1 conduction ratio. Just by looking at that alone, can you tell if it's Type I or Type II second degree block? And so I'm going to go back a couple slides just to let you look at something and think about it. Now, I realize I marked this down as being second degree Type II with a prolonged PRI, but that is only because looking at this patient, that's the best answer I can give. In real life, you've got more time. You've got a patient in front of you. You might actually be able to figure out which one it is. And so here's the answer on how to do that. If you have a patient who's got the 2-to-1 conduction ratio, the way to figure out if you're in Type I or Type II, the quickest and cheapest answer, of course, is to do vagal stimulation. What happens is you do the vagal maneuver, or you can do a carotid sinus massage. I don't recommend that right away, or at least if you're not ready to do something a little more exciting in case it works too well. But what can happen is if you do either one of these and you stimulate the vagus pathway, it will slow down the AV node, AV junction's ability to conduct, and it makes the block worse if it's Type I. And so that person will go from, dropping every fourth beat to dropping every other beat. Like, it'll get notably worse in terms of the block. Now, when you do a vagal maneuver, it also slows down the sinus node. And what happens there is because the sinus node slows down, if your block essentially goes away and all of a sudden you're doing 1-to-1 conduction, you're dealing with a Type II, second degree Type II. And that's just a really cool, neat thing, isn't it? Just a little bit of vagal maneuver or carotid stimulus will wind up potentially giving you the clues to tell if you're in a Type I or a Type II. Again, stability of patient. Is the number one concern. If they're unstable, don't worry about this stuff. It doesn't matter. But if they're stable enough and really want to dig down, or if a cardiologist comes in and does this, now you know exactly what they were trying to accomplish. The other option that you can do is to use atropine, which of course causes tachycardia. And that atropine will actually speed up the AV node and will make it stronger. And when you stimulate the AV node, you will actually have more conduction. So a patient that was doing P wave, QRS, P wave, nothing, will then do P wave, QRS, TP, QRS, TP. So instead of having the 2-to-1 block, here it'll actually give you a pair of beats before it drops. So, which is good because then that allows you to measure the PRI and tell the difference between type 1 and type 2. If you give them atropine in a second degree type 2 with a 2-to-1 block, nothing will change. Atropine won't make a big difference. So they're either in type 2 or potentially a third degree block. Either way, keep these things in mind. This is really fun. Ask your cardiologist about it. Maybe he'll tell you a fun story, or she will tell you a fun story. All right, so this is one of the many strips I've collected over the years, and this one does a really great job of illustrating how blocks can progress, sometimes rapidly. I'm going to go through and get this one marked up, and then we'll talk about what exactly is going on. To start things out with, these are a little bit longer than 6 seconds by a hair, and that's just to help make sure that you can see what's going on. Ultimately, it's about, it's pretty close to 12 seconds. And you can see how we start out with what's essentially sinus rhythm, and then we go into a block, and then we go into a worse block. Now I'm going to throw on the markings and we'll be able to tell a lot of what's going on. Start here. That's a 2 for the QRS. We'll measure from here to 7. And 21. So you can already see the regularity on those P waves, what's going on there. And we'll measure again down here below. This is one continuous strip from one to the next. So to be able to compare these so close side by side really does help show off exactly what's going on. And we'll start from here to here. And both of these are 19. So we have that and that. Okay, so let's start walking through this. What do we got? Well, our initial rate, starting from here to here, is actually 19. So we have equals 79. So we're essentially in sinus rhythm to start with, correct? P waves are upright, they're uniform, all that jazz. But then what happens as we go on, the latter half of that top strip only has 2 beats in it. So your heart rate's, it'd be 40 or less. In fact, if we mark these out from here to here, that has a total of 42 spaces, and so 42 gives you essentially 36. So you go from sinus rhythm to bradycardic, and then of course the other strip down below only has 2 beats on the entire thing, and so that's in the 20s. All in all, pretty darn slow. We start out regular initially, but then progress into significant irregularity. In terms of a pattern, well, we had no unique pattern at the start because everything was regular, but then we got into a 2-to-1 block, and then it got even worse beyond that. So I can say that we don't have a specific pattern. We don't have any ectopy. We do have more P's than QRS's, though. Now, if we look through at all of our P waves, they are upright and uniform. If you're wondering, in terms of regularity, where do we sit? You know, initially it's 20 and 21 and kind of bouncing back and forth, and then it goes into the 19s. I think a lot of the reason is, one, people will vary a little bit over time, but also as that block got worse, that may also have been contributing to why the P to P changed a little bit. Ultimately, we'll say that it's pretty darn regular, though. P's are greater than QRS. You know, we initially start out with a 2-to-1 block. I'll just kind of mark these a little bit. We don't have any hidden, which is always good, makes life a lot easier. So we start out with a 2-to-1 block initially, and then that improves, and then that gets worse. Now, as for the PRI, that remained consistent throughout. So we do have 7 times 0.04, 0.28. And so that is a first degree AVB, at least while it's sinus rhythm. If you remember our discussion about what to do in the case of a second degree type 2, the rules change a little bit. We use the phrase prolonged, but keep that in mind that we did have that to start with, and then it continued on as the block got worse. QRS, those are uniform, the ones you can find. They are RS pattern. We measured that as a 2 times 0.04 equals 0.08, which is normal. Nothing special going on there. So ultimately, what would you say if you had to talk to a physician and tell them what you saw? Well, I would say that the patient started out with sinus rhythm with a first degree AVB. That turned into second degree AVB Type II, and then it was a 2-to-1 conduction with prolonged PRI, and then that ultimately turned into second degree Type II high grade block. And truly that's what it is, right? That initially you just drop one and oh, okay, it came back and then dropped another, and then you drop that one and you drop this one, and rather than the pattern continue, it actually gets a lot worse. And you drop, 4, maybe even additionally 5 or 6 beats in a row before it kicks back on. That's what we're trying to illustrate here. At the end of the day, check on your patient, take care of them according to ACLS protocol. High-grade AV blocks occur in second-degree AVB Type II. Which of the following are correct criteria for this interpretation? First, the PRI of conducted P waves are wildly inconsistent. No, that's third-degree block is what we're talking about there. B, 2 or more consecutive blocked P waves. Absolutely, that's actually one of the key criteria of a high-grade AV block. Some P waves continue to be conducted into the ventricle. Well, that's actually the definition for second-degree blocks, right? That some of the P waves are blocked. Third degree has no P wave conduction. So that one's out. So right now we're looking at B and C as correct. D, PRI width increases progressively before dropped QRS. Well, that's second degree type 1. So at that point, that one's off the table. So when you're left between E and F, F is definitely your answer. Your patient started the shift in rhythm A. Later, the alarm sound and you see rhythm B. What action would be most appropriate? And so just looking at these, they're starting off in what appears to be a nice clean sinus rhythm. But then here it looks like we have a second degree block, and that's going to cause bradycardia. So you have a patient with a new onset bradycardic rhythm. How scary is this, particularly that it's a block? It's not a false alarm, because we know that. Would we have the CNA evaluate a patient after a rhythm change like this? No, we wouldn't. So this really comes down to, do we call an RRT? Do we just notify the primary nurse? Or, do we contact that nurse immediately and escalate if unable to contact? In this case, because this rhythm has such a potential to get very bad very quickly, I'm going to say that it's the emergent contact of that primary nurse and definitely escalate if unable to reach them. All right. Going over third degree heart block rules with the advanced arrhythmia. Everything is the same as it was beforehand, except we're actually going to take the time and figure out what the escape rhythm is. So again, your atrial rate is going to be normal, essentially. You're going to have P waves marching along without any care in the world. But with your ventricles, ventricular rates, they're going to be slow, definitely bradycardic, but the speed at which they're bradycardic is definitely going to be a factor. If you're sitting in that 40 to 60 range, you're probably dealing with a junctional escape. If you're lower, let's say 20 to 40, it's likely to be a ventricular escape. Now, after saying that part, I'm going to skip down to the QRS section here for a second. The next part to help answer that question is, what is your QRS width? How wide is it? Because if your QRS is narrow, you're likely dealing with junctional escape. If the QRS is wide, you're dealing with a ventricular escape instead. So the narrow versus wide, those are going to help clue you in onto which one you're dealing with. Yes, ventricular escape is worse than junctional, because junctional should at least be able to perfuse for a while, whereas ventricular escape truly is that last-ditch effort by the body to keep alive. Back up to regularity. Both of these, whether it's junctional or ventricular escapes, very, very regular. P waves, you should definitely have more P waves than QRSs. They'll be upright and uniform. The PRI, again, this is what makes it third degree heart block. You essentially never have two PRIs in a row that are the same. It's 4 and then 12 and then back down to 6 again and then up to 24, just completely wacky. And that's a sign that maybe you should be looking at a third degree block. Additionally, those P waves love to be hidden in the QRS or the T waves, so always be on the lookout for those. Finding out your P wave regularity and then drawing them out on the sheet, that's what can help guide you to maybe finding some hidden ones for sure. A thing I'd like to introduce you to, or a concept I want to add to what you've learned about the third degree heart block beforehand, is this idea here that this is third degree heart block without an escape rhythm. This is true, pure third degree AVB. It's also known as Ventricular Standstill, which is exactly what it is, right? That the ventricles have stopped doing anything, but it's not asystole, because asystole would be a true flatline. In this case, you have atrial rhythm, well, at least atrial electrical conduction, but nothing beyond that. You're missing all of these QRSs through here. Things that would clue you in, of course, is the fact that this is pretty low amplitude. There's nothing that really sticks out as a true QRS. This patient's clinically dead. There's nothing going on that's going to keep them alive at this time. If we worked it out, there's 6 beats across here, so you could do atrial, /60, ventricle 0. It is regular, no pattern, and no QRSs. As for the P waves, they're upright and uniform. They are definitely regular. We have P's only. Of course, there's no PRI that you can measure because you don't have a QRS, and none. Again, this is that true dissociation where everything in the atria, no matter what it is not going to be conducted down through. If you ever do come across this or have a patient that has this go across their screen while you're monitoring them, you know, this is ACLS at its core. I think you're beyond the bradycardic part of things, and you will need to be doing compressions. Until you can get pads on and do pacing. That's what you need to do in this scenario, because they need blood flow. Once the pads are on, you can then crank them up and be able to use temporary pacing to augment things and get them going again so you can stop doing compressions. But yeah, this could be any number of things triggering it. But I just wanted you to see this, and so now visualize this when we go forward and we look at other third degree blocks, that you just have this P wave clipping along doing its own thing, but then the escape rhythm is just layered on top of it as an additional, essentially a second rhythm on top of what's going on here. Advanced arrhythmia wise, we have the strip in front of us here. It's third degree heart block. This is the exact same one that you saw in basic arrhythmia. This is all the markings. So if you want to pause this, look through it to refamiliarize yourself, or even go back and rewatch that one side by side, whatever you prefer. Ultimately, what I want us to hone in on is these items here. I'm actually going to change color to blue so it stands out a little better. We are bradycardic with a heart rate of 30. We definitely are in the third degree, like we mentioned, and we have a narrow QRS. with those items being in place, that's enough information to tell me that we are in a third degree AVB with junctional escape. And you might ask, because if you look back at the slide before where it talks about, well, you know, the rate range is from 40 to 60 for junctionals, but it also says that they're narrow. Which one is more paramount? Well, honestly, the answer is how wide the QRS is. If that QRS is less than 0.12 for your QRS, then it's a junctional escape, plain and simple. Another question you might have, just to touch on this, is I thought junctionals were supposed to have inverted P waves, right? Well, that's true, except remember, a junctional beat starts in the AV junction and is conducted backwards. And so if you have this heart and you're expecting that wave to travel backwards up through the atria, that's what gives you the negative P wave, right? The one that's upside down. But in third degree heart block, this has been severed. There is no retrograde conduction. Therefore, you'll never see that quote unquote upside down P wave, meaning you just get a QRS all by itself. Meanwhile, the atria is doing its own thing with its upright P waves like these guys here. So that's the reason why you won't see those. So in diving deeper here as part of advanced arrhythmia, this is again the same strip that you saw with basic arrhythmia. All the markings are on there. You can take a minute to get refamiliarized. But what I'll just draw your attention to right away is that we've got a heart rate of right around 20 to 25. So we're very bradycardic, very slow. But the QRS is right at 0.12. It's still technically normal and still technically a narrow QRS, even though it's a bit to the wider side. Ultimately, in terms of treating this patient, whether it's wide or narrow doesn't matter. The fact that it's slow is what matters the most. So that's what I'm most excited about. And so for ACLS, that's what you're going to go by, is the bradycardic algorithm there. In terms of actually deciding what the escape rhythm is, though, we can take the few things that we know. That is, the rate is, let's write this down here. Rate is slow. We have a narrow. I will also make mention that the T waves have the same direction as the QRS, or the same direction as the R wave, so they're not inverted. I'll say upright. And yeah, we've got that QRS on top of P's. But it meets all that criteria for the no retrograde conduction, things like that, especially beat 1 here, where you know that QRS is right on top of that P wave, which is pretty interesting. Ultimately, the narrow kind of clues you in that this is a it's a junctional escape that we're dealing with. So third degree heart block, or third degree AVB, so I do want to take just a little bit of time to tell you about this patient. I actually had one that was exactly like this. She came in, she was in junctional escape, and this was her heart rate for the entire night. We sat there for all 12 hours until she could get her permanent pacemaker put in the next morning. She never went any slower than this, and she really wasn't terribly symptomatic as long as she didn't move. The second she tried to sit up in bed or move around, that was enough stress on her body that she just felt really crummy and her blood pressure would drop. But if she sat perfectly still, didn't do anything, we were able to ride it out and get things taken care of the next day. But there it is. All right, this is our final one, and it is also the most challenging. So we'll walk through this as best we can. We'll do everything that we've done before. 1, 2, 3. Our regular, no pattern, no ectopy. We have P or greater than QRS, which we have to prove. In terms of measuring between the R to R, from this one here all the way to this R wave way out here is 50. Pretty rare, but those two worked out together. In terms of looking at the atrial rhythm, this is the part where it actually gets quite challenging, and we're going to look at the P waves on this one. The most obvious ones that you see is likely to be this one here, because it's right in front of a QRS. There's this one here that's a little further out, and then there's this one here that's further out yet, which is pretty cool. If we measure out the if we measure out the PRI for those specific ones and figure out the distance and regularity, you'll see that this one here all the way across to here is a distance of 46, and that my PRI in that case is right around 4. Now my next one from here all the way across to the next, oops, sorry, that one's also right at 46. Okay, those are both 46. If I measure out the PRIs for both of these, I get about 8.5. And then I'll measure just for consistency from here to about there. That one comes out to 14. So I have progressively lengthening PRIs, which may think that, okay, this could be a second degree type 2, and maybe another beat or two down it'll wind up dropping. Now that very well could be the case. However, if you look closely, you'll notice that there's some irregularities, and the irregularities are not consistent. If you look right here, right after that T wave, now that could easily be a U wave or something like that, but you'll notice the two of them are different. If we assume for a moment that those are P waves, and I'm actually going to change colors for this, and that they start right around here, and that this one starts pretty much around the same spot. Let's see here. Starts right around here. What you find is just by marking it, those wind up being .23. So those imaginary little dots or imaginary little bumps are actually really subtle P waves, especially when you consider how small these other ones are that you can see really well. At that point, you've got a 2-to-1 block now, that you've got 2 P waves for every QRS, but because everything's so slow, and the fact your PRIs are getting longer despite the fact that you've had a dropped P wave or a dropped QRS, is what shifts us into this 3rd-degree block thinking. Because now, instead of having 3 P waves and a heart rate of 30, I've actually got 6 P waves, and at 23 small boxes apart, that actually gives us a rate of about 64, which is a whole nother game. So we've got a heart rate of 64, a P wave rate of 64, but due to the block, we're down in the 30s, which makes sense if you're doing a 2-to-1 block or so. My P waves are upright. They are uniform as best they can be. They are regular. I do have more P's than I do QRS's. So we're looking at a block. If we write out those PRIs again, we're looking at 4, 8.5, 14. They're getting longer. There's no reset with the dropped beats. I'll go ahead and draw our usual orange one to indicate where we're assuming there's some dropped beats at. And in fact, if you measure out the next 23, that we go maybe about, this is where our next P wave should be hiding at, and it would be within this T wave, which then would fit the pattern appropriately because I don't see anything in this zone out to the side. So we have wildly inconsistent. And no reset. And that's 3rd degree. As for the QRS's, how do we measure those out? Well, I'm actually going to go vertical for these, and I'll do this in blue so you can see them a bit better. And we'll go from right here. And when we're measuring these, because you see how the S wave actually takes a bit of a break, it stops and then turns, so that you've got your tip of the S wave down here, but then it comes up and it shifts directions. That's actually what we can use, is at that spot, because that's the J point, which is just about a half box in. At that point, that is 4.5. So we're uniform. We have our S pattern, and we will go with and that gives us 0.18 sec, which is wide. Now, having all that put together, that we're bradycardic in the 30s, we're in a 3rd degree block, and that we have a wide QRS, we are in 3rd degree with ventricular escape. And that's that. Why is 3rd degree heart block important? Why 3rd degree AVB? Well, honestly, because it's one of the deadly rhythms, one of the deadly arrhythmias. If you really think about it, this patient's heart, the top and the bottom half, are completely separated from one another, dissociated. They're not communicating electrically. That means that this patient is in for a rough time unless they're very, very lucky. The things that come out of this are, why is it important? Well, acute heart attack, acute myocardial infarction, acute coronary syndrome, whichever one of these you want to go with, that's an upset heart, especially if it's new onset. Usually they're going to present with syncope because all of a sudden they go from a heart rate of 60 to 80 down to a heart rate of 40 to 20. It's so fast and drops so precipitously that it's a pass out that winds up bringing them in. If they're lucky, they wind up with a heart rate. Sometimes it just might be that, that fun statistic where a large majority of people pass away with their very first heart attack. Things like this are the reason why. If they are fortunate enough to have a good escape rhythm to keep them going, you still have the risk of exacerbating an underlying problem. Because let's be honest, if you're to the point where you have this type of heart issue, you probably have multiple comorbidities. So it can take a bad situation and make it worse. So what does it present like? What does it look like? Well, they're going to have that irregular, well, it actually shouldn't be an irregular pulse. It should be perfectly regular if they have an escape rhythm. Ultimately, it's the bradycardia that we care about because of that low cardiac output. The syncope, like I mentioned, the low blood pressure, the shortness of breath that can come with it, this low BP is the one that we're really worried about. We can have change in level of consciousness. Treatments, well, depends on if they're truly unstable, which they will likely be. You're going to follow ACLS. You're going to give them atropine. Atropine will probably not work at all. So be ready because temp pacing with pads is going to be your first go-to to help keep them alive. And then probably transition into either a temp pacing wire or a permanent pacemaker, depending on their problem. We can definitely try medications in the meantime to help bridge the gap. That's perfectly appropriate. We just have to see what winds up working out in their favor. Ultimately, what's going to cause this? Well, ischemia, we talked about that. Cardiomyopathy, enlarged heart, hyperkalemia, elevated K+. Meds, same as before, anything that would cause a severe bradycardia. So that can be your beta blockers, cardizem, and you think about it, those are the meds we give for AFib patients that are running too fast because it helps slow down that AV node and the conduction through them. Well, now what happens when those drugs work too good? Now, none of the conduction could go through, or a very, very small amount. Your high vagal tone is one, and then inflammation of the heart can do it too. Either way, it's that ACLS approach to things that always take third degree serious. That's why we make a big deal about catching it every time. Which of the following escape rhythms occur in third degree AVB, complete heart block? And your choices are supraventricular escape, junctional escape, atrial escape, or ventricular escape. This really is as easy as going back to the slide and seeing the options listed. There's only two. Atrial escape is not a thing, and supraventricular escape is not a thing either. Really, we just focus on junctional and ventricular, so that gives us both B and D being your answer here. So junctional escape and ventricular escape. When providing care to patients with third degree AVB, also known as complete heart block, which of the following are priorities? So this is a question of you have a bradycardic patient, and this is one of those potentially lethal arrhythmias. What are you going to do when you care for this patient? You're going to visualize them, absolutely. Go lay eyes on them. You're going to check for a pulse. You're going to collect vital signs, because that's just what you do when you're checking on a patient, right? If their heart rate is so low or they don't have a pulse, you may have to initiate CPR. You also need to confirm whether their DNR, DNI status. That may absolutely change the way we react to that situation. Ambulate to the restroom? Absolutely not. Why would you walk your patient when they're in this bradycardic rhythm with probably low cardiac output? Definitely don't ambulate. Checking level of consciousness? Absolutely, because that's part of visualizing the patient, right? You talk to them. And then move the patient from the floor to the bed immediately. If they happen to have had a syncopal event because of this and passed out, leave them on the floor, keep the scene safe, work on them there. When there's enough help, then you can move them to the bed, but don't make that your first priority. So yeah, ambulation and moving the patient doesn't need to be done right away.